In any case, I don't think I'll convince you to transplant everybody. But I do think, and I, like Dr. Chesson, hope that we'll all be historical relics at some point, but then that we'll have totally new treatments that are totally non-toxic, but we are 2015. What do we do with this patient? And I will try to convince you that there's still today a good role and actually an improving role for allogeneic transplantation. Let me start with a couple of patients, some real-time patients. How do I get the next slide here? Here we go. There you go. So the first patient was a 38-year-old male who I saw now 2 years ago, perfectly healthy, never smoked, never had any problems, active person. The only bad thing that happened to him at age 34, he developed CLL. And he may have some family history. Rick knows him. Rick knows both of these patients. And his father also had lymphoid disorder. So these are the treatments he had had. He had had FCR, he had had FR, didn't work. Then he had had an anti-CD20 that led to capillary leak. Then he had had ofatumumab without effect. Then he had had bendamustine and rituximab. Then he had received high-dose methylprednisolone and rituximab. None of that really worked. He had a partially controlled CLL. He clearly still had CLL. He was also profoundly pancytopenic. He was transfusion dependent. He was heavily iron overloaded. And we had a lot of debate. He went to about every center in New York, arguing, is this now a form of MDS that is underlying this? Is this CLL? Is this a combination of CLL and MDS? What are you going to do with him? That's patient 1. Patient 2 is a 57-year-old gentleman with a long history. On the other hand, he's not that healthy. He's overweight. He has cardiomyopathy, he has had a melanoma, he has, with all his prior treatments that I will show on the next slide, he has had fungal infection, cellulitis, partial small bowel removal, and so forth. The one nice man, he never smoked. That was in his favor. And he had been diagnosed at age 47, 10 years earlier, and had received all the wonderful therapies that were in existence since then. CVP, FR, PCR, bendarituximab, cytoxan-ADA vincristine, methotrexate vincristine, chlorambucil, thalidomide, alemtuzumab, high-dose methylprednisolone, alemtuzumab, and forget about the last one, which is actually ibrutinib. And he was also profoundly pancytopenic, still with active CLL, and he had a cytogenetic abnormality that indicated a underlying MDS. So these are the most frequent patients with CLL I get referred these days, and I get them. You know, they exist, and so do you give these ibrutinib? Do you give these the novel, wonderful agents? I would say ibrutinib, that's another drug they will take. One of them had already received that. It's another drug that they will receive lifelong. Yes, minimal residual disease doesn't matter anymore. I think we'll have to talk about that 5 years from now. And side effects, does it cause, is it associated with transformation? Who knows? It's hard to know. Right now, not. Right now, it's all the prior treatments. Bleeding tendencies, atrial fibrillation, I actually wasn't aware of. I don't think these are great options for these patients. One, they're already quite myelosuppressed to begin with. So what about an allotransplant? Well, it's a one-deal thing. It's potentially curative, and my colleagues will say, but everybody dies. I don't think that's true. There's a risk for graft versus host disease, and I'll talk about that. I think we will continue to do transplants, and I think there's reasons to minimize graft versus host disease and make transplants more tolerable. There's a real risk for treatment-related mortality, But I think that can be reduced if we apply transplants earlier on in the course. So you see these two patients, and then we get these patients, and then patients don't do well, and then we get told transplant is too toxic. And my argument is you should have sent these patients 5 years earlier. So it's a lose-lose situation. There's a risk for disease recurrence, nobody will deny it, but I will make a point that perhaps this is the moment to integrate these cellular therapies with the novel agents and to increase the efficacy and reduce the toxicity of transplant and reduce the need for lifelong administration of these agents. Perhaps we can expose the patients to a prolonged but not lifelong treatment with such agents after transplant. Ibrutinib, again, one of the few slides, but I want to point out that on the right side, refractory relapse disease had only a 2% CR rate, and next slide, refractory disease, after 2 years, 20% had already progressed, and that was even worse in patients with 17p deletion. So at least to this first patient, we talked about ibrutinib a little bit. He was absolutely uninterested. He had already failed a lot of treatments. Then what about transplant? Let me show you a couple of slides only. I don't think I have to convince you of the difficulties of transplant. It's a complicated treatment, but on the left side, well, let me start with the right side. On the right side is a slide from Isaac Khoury from MD Anderson, their long-term outcomes, and he subdivides this by patients who had low CD4 count at the time of transplant and a low IgG, the hypogammaglobulinemic patients, and the patients who do not have these features. And the patients who have normal immunoglobulins have fewer infections, fewer complications, and have actually at 4 years about a 70% survival. And these are again relapsed patients, so that's really quite impressive. This tells me there is a need for transplanting less sick patients. There may also be some art in transplant, not really art, but some way of perfectioning this complicated treatment. It's very different from chemotherapeutic treatments. You have to do everything right. You have to do your viral prophylaxis right, your infection prophylaxis, your graft source, etc. So I do think there's experience here that counts. On the left side, German study, patients who were monitored by MRD, for MRD after transplant versus patients who were not monitored. And those who were more carefully monitored did much better as far as event-free survival, because their GVH prophylaxis was adjusted and other treatments were introduced. So the red curve is patients who were carefully monitored, and this is before the ibrutinib era or the idelalisib era. If patients were monitored and at the first sign of disease, there was an intervention, be it a lymphocyte infusion, be it Rituxan, the duration of remission became excellent. That makes me think this is where we should go with transplant. We should monitor these patients. Some will have early relapses, and we can probably salvage them in a more efficient way. Patients that were MRD negative in those German studies at 12 months, the green curve on the left, once you were 12 months out and you were MRD negative, you relapsed very, very rarely. So if we can keep these patients in remission for a year after transplant, we're in good shape. If they were MRD negative at 12 months, they didn't even become MRD positive. That's the curve on the right. So I think transplant can be done, transplant can be curative, transplant can be optimized by careful post-transplant monitoring and by optimizing supportive care. But don't you need graft versus host disease to stay in remission after transplant? And doesn't graft versus host disease cause a lot of morbidity and chronic morbidity and late mortality? Yes, it does cause chronic morbidity, and yes, it does cause late mortality. And yes, it is to be avoided. There are, in this day and age, very few data suggesting that GVH is necessary to obtain your GVL effects. And I will just show you one slide. This is a very recent publication from IBMTR, I believe, looking at long-term survivors, patients with all kinds of leukemia, who were a year after transplant. These are 7,000 patients, so quite a powerful analysis. About half had chronic graft versus host disease, and about the other half did not. The ones without chronic graft versus host disease over the subsequent 3, 4, 5 years had much higher treatment-related mortality, up to 20% still. So chronic graft versus host disease remains fatal and not just morbid. Did they have less relapse rate? No, they did not. There was absolutely no effect of chronic graft versus host disease on relapse rates except in CML. The presence of chronic graft versus host disease prevents relapse in CML, a disease we rarely transplant these days, but not in AML, ALL, or MDS. Admittedly, very few CLL patients are there, but my impression is that the same applies to CLL patients. We need to avoid graft versus host disease, and we can, and it will not affect our late relapse rates. And I think we can then intervene much more efficiently with subsequent drugs, the newer drugs, to really affect long-term outcomes. Interestingly, the BTK inhibitors may have a therapeutic effect in graft versus host disease, and that's so. Last point, most people don't have matched siblings, or their siblings are elderly if you're in your 60s, but we have unrelated and umbilical cord blood donors. Let me tell you how these two patients ended up. The first patient did not have a related or unrelated donor. He had a procedure that we did, a cord transplant, supplemented with an adult graft to assure rapid recovery. He had conditioning with fludarabine, melphalan, and ATG. He engrafted by day 15. He had a mild adenovirus pharyngitis. He had a strange polyarthritis that was transient. He had urticaria. We are currently 22, probably 23 months after transplant today. He's fully back to work. He is MRD negative. He has no GVH. All we are doing now is phlebotomizing him for removing the approximately 20 grams of iron that he has accumulated prior to the transplant. And if these German data on 1 year MRD negativity are any sign, then this man should have an excellent prognosis without having exposure to more treatments. The second patient had an unrelated donor, had the same conditioning. Again, Dr. Chesson said Campat is gone, but we still use it for GVH prophylaxis, one of the few here, but in Europe quite commonly. He had some problems early on, but he's 27 months post-transplant, also in remission. Dr. Furman follows him now, I think, and we last saw him about 3 months ago. He has some social issues, but is in remission from his CLL for the longest time, ever since he was diagnosed. And with that, I thank you. These are all my colleagues of prior institutions and of current institution, and all the people who really do the work, some of whom are here in the audience, actually. Thank you.